Okay. Are you ready?
Yes, Joseph. I'm not sure if there is anyone who is willing to join me today in the discussion. So if there is anyone, you can just raise up your hand and we can discuss together. So Joseph, let's proceed.
Yeah. So today, as a big difference, we'll be having a 27-year-old female who presented with anemia.
This is interesting. I know it's not one of those complaints that people are used to. Yeah, but so sometimes someone presents with they will come with symptoms. Maybe they are complaining of fatigue, headaches, easy fatigability, and many other symptoms, and then you establish the patient has anemia. So that is just the beginning of the journey because you need to figure out the cause of the anemia. Uh, so the way I approach anemia is I think that it's a very broad clinical problem because it's not a complaint, but it's a very broad clinical problem, and there are so many things that so many differentials to consider. But just to start, I categorize them that if someone presents with anemia, this could be a problem with it could be a problem with the factory, that is the bone marrow, due to bone marrow failure syndromes like aplastic anemia, which we know, and therefore it will be interesting to see and know if there are other cell lines that are involved, the platelets, the WBCs. But so it could be an issue with the bone marrow, and there could be a number of things. It's either the bone marrow is failing on itself, or it is infiltrated, for example, by malignancies like multiple myeloma and many solid malignancies, or it is infiltrated by infections that form granulomas like tuberculosis, like endemic mycosis. But you can also have viral infections that lead to anemia and pancytopenia generally, like CMV, EBV, HIV itself, parvovirus, and many others. So that is the bone marrow is having an issue. But then, so it's an issue with hematopoiesis. But another problem is a problem of maturation. And when you talk of a problem of maturation, you mainly talk about the raw materials that are needed to produce the RBC. So you are talking of vitamin B12, folic acid, as well as iron, and iron can go both ways. It can be so certain levels of iron deficiency can lead to a maturation problem, but other levels of iron deficiency can lead to impaired erythropoiesis itself. And then another one is peripheral destruction. So you are talking of hemolysis now. If we are just sticking to the RBCs, we are talking of peripheral destruction from hemolytic anemias of all sorts, like autoimmune hemolytic anemia, drug-induced hemolytic anemias, uh, hemolytic anemias which come from infections like malaria and other infections. But you can have increased, you can also have sequestration and increase the destruction, like in hypersplenism, which has many causes. And then of course another one is acute blood loss. Someone is bleeding from the GI, whether through hematemesis or hematochezia or internal bleeding or any other sort. So the list of differentials is very broad. So let's hear the more information and see if we can narrow down.
Okay, thank you. That's a good start. She reports that she started experiencing episodes of anemia since primary school. She has had multiple episodes of blood transfusion, and she denies heavy menstrual bleed or passing Melena stool. She reports that her normal HB is around 7 to 9, and when it goes below that, she experiences lightheadedness, easy fatigue, general body weakness. She denies weight loss, abdominal pain, bloating, diarrhea, joint pain or swelling, fever, night sweat or rash. Reviewer system, nothing significant. Past medical history, nothing significant. Meds, she reports that she has self-dewormed herself several times with albendazole or mebendazole. She also used multiple times oral iron supplements, but she says they never helps her. Family and social history, she has one sibling who had severe anemia during pregnancy and required BT, but otherwise, no other relative with blood issues. She doesn't have any diet restrictions. She works as a medical doctor, which was easier for the case. Yeah, general exam. Let's proceed because there is nothing in general exam except that she was pale. Vital signs, other aspects of general exam were normal, and the systemic exam was also normal. Yeah.
So let's, yeah, the HPI. So these are episodes of anemia since primary school, and multiple episodes of blood transfusion. No, nothing in keeping with the recurrent blood losses like heavy menstrual bleeding or passing melena, and then so the steady, we can call the steady state HB, between 7 and 9. Okay, so on examination, I pick that there is no. I pick that there is no the patient was not jaundiced, but I would also be interested to know that during history taking, does she report any episodes of jaundice? Joseph, if you had that information.
No, no jaundice.
Okay. Yeah, so now at 27, she has been having these episodes since so right from maybe school years or early teenage years. So it's a chronic history of anemia. Now this history is not very helping. I mean, well taken, but then as you can see, there is we do not seem to have anything that is pointing us in the direction of what exactly is the cause, because most of these things that we talked about do not seem to be reflected in this history. But then uh, I believe so. These are some of the assumptions that we make, because this patient has had multiple episodes, and therefore it's very likely that that is the abnormality that has been picked on examination. But then, so another way, so I'll just wait and see the CBC, the current CBC. I think it will give me some information, but then uh, I would be interested to know if the other cell lines are involved, if this patient is having recurrent fevers that could be pointing us in the direction of leukopenia, also any bleeding tendencies, which of course some we've been told that they are not there, like melena, heavy menstrual bleed, uh, in the direction of platelet abnormalities, whether quantitative or qualitative. But then those are we do not pick that from the history, and therefore if we just deal with the problem of anemia, and so this is provisional, but then I will wait and see the CBC, and then I hope I can make some progress from there. But if we're just dealing with anemia, uh, and this is anemia that starts from childhood, yeah, we can term that because it's since primary school. So it's either during the school years, I'm talking about maybe from 7 all the way to teenage, and now she's a young adult presenting with still presenting with anemia with history of multiple blood transfusions. So another thing is that this is a patient, not very likely, but then so there are some unusual cases where people are diagnosed with hemoglobinopathies like sickle cell disease uh, late in life and not earlier on. So uh, I would also be interested, although yes, Joseph has already told us that this patient does not report any episodes of joint pains or swelling. So for them, when they get the crisis, it's more of the bones. So bone pain. If this patient has had histories of bone pains, we are told there is no jaundice because patients with sickle cell disease, the episodes when they get hemolysis, and if the hemolysis is significant, you can pick. So that can be picked by jaundice. Although someone can have hemolysis and not have jaundice when the bilirubin levels are not above a certain level. Yeah. So still with this history, we just know that this is something chronic, and therefore we may not entertain those acute issues like acute blood loss. Although yes, if a patient has ongoing episodes of blood loss, but which are not very drastic, then they can eventually end up with iron deficiency. So, for example, this patient is deworming frequently, but worm infestations, especially in low income settings like ours, people can have anemia due to worm infestations, and so later on ending up with frank iron deficiency anemia. But then she deworms frequently. So as I said, hemoglobinopathies, I think they are worth to be considered, although it's unusual presentation. It's an unusual presentation. And then iron deficiency. Yes, someone can have iron deficiency for a very long time. So iron deficiency is one of those things that I'll be interested to that I'll be interested to look more into by. So I'll start with the simple CBC, and because the patient has been having multiple episodes of blood transfusion, it's recurrent, and therefore a CBC will be important. A peripheral smear, depending on what we see, a reticulocyte count, and then iron studies might be very important, and therefore iron deficiency anemia itself, I think, is one of those things that I need to consider at this point. So yeah, so the raw material deficiencies that I talked about, including iron deficiency, and then uh, issues of maturation, particularly, or peripheral destruction, like so there are some so hemoglobinopathies are more of peripheral destruction, but then you also have membrane abnormalities, which I have. Antimon says they cannot hear me. Joseph, can you hear me? And everyone else, can you hear me?
Yeah, I can hear you
Yeah,
very well.
Antimon, I'm not sure if it's the volume of your device. Maybe that is very down. So you can try to check on that. Okay. Yeah, so a number of things. So Joseph, maybe not because I have not picked any signals that can help me narrow down. Let's just proceed to the initial labs, and then I can discuss from there.
Okay, so let's see the labs. Uh, CBC, she had a normal white count with a normal differential. She had a severe anemia of 5.4, hematocrit of 19.9, RBC was 3.24, MCV low at 61, MCHC both low, platelet normal 291, PDW 12 low, CREA and BAN were normal, liver enzymes were normal, bleeding indices were normal, and triple serology were also negative.
Okay, so as I discussed earlier, I was very much interested to see. So the other cell lines, we see the WBCs are not touched. The platelets are normal. So we see a severe anemia, which is microcytic hypochromic. So a microcytic hypochromic anemia. Well, I saw the red cell. I mean the so Joseph, what you presented is that the red cell distribution with the 12. the 12 there, or is it something else?
So it was written printed distribution with this. Uh, I don't know. I think it's the same because in that paper there is no RDW. I saw the PDW and I looked it up. It's PD. It's a printed distribution with.
Yeah, so I seen some CBCs, they have that, but then I've never checked to see what the platelet distribution width tells us. So what I consider mostly is the red cell distribution width. Yeah, uh, so we see a microcytic hypochromic picture. Yeah, so I'll just go ahead, and I know again, when you see a microcytic hypochromic anemia, the issue is not iron itself, but then am not very confident with the other causes of microcytic hypochromic anemias. I mean, except you can also talk about some membrane abnormalities like spherocytosis. They can also be small RBCs. But yeah, so one of the commonest ones that we talk about is iron deficiency anemia. And therefore, so for this patient, what I'll do basically, I need a peripheral smear. I also need in order to see if the bone marrow is reacting to this level of anemia. If it's appropriate, I need a reticulocyte count, but I also need iron studies. So Joseph, let's proceed with other labs or anything else that you have.
Yeah. So other labs, ferritin was 1.91, extremely low. Transferrin was 334, normal. The retic was zero point 0.6, haptoglobin 45, normal. LDH was 180, and the B12 was 537. Oh, yeah.
Okay, so let me check this. Well, so it's safe to say that the reticulocyte count that we see there, because it's in terms of a percentage. So basically that is low. That is low when you consider the degree of anemia. A hemoglobin of 5.4. If the bone marrow is responsive, we expected that platelet, I mean the reticulocyte count to be high. So the hemoglobin was 5.4, if I remember correctly. And can I see the normal range, or I'll just take an average, let's say a hemoglobin of, can I see the CBC, Joseph? I'm trying to make some calculations here. Okay, we do not have the normal range for the hemoglobin for this lab, but so yeah, in terms of percentage, the reticulocyte count that we see there is low for the degree of anemia. And I believe even if you try to calculate the reticulocyte production index, it will still be low. We expected the bone marrow to be more reactive than that. So that is one of the conclusions that I make here, although I might be misguided in a way. This bone marrow is not reacting adequately. So a ferritin. So you did not do iron levels, Joseph. If you have details for the iron levels, although
I
yes,
mean, serum iron.
yes, serum
No,
iron.
we ordered iron panel. The lab when come back, there was no serum iron. They just brought this.
Okay, so what's the transferrin that we see there? So of course, ferritin being low is also pointing us in the direction of iron deficiency. So for transferrin, what is more informative is we check the transferrin saturation. And I think so if we add the transferrin saturation and see what the exact percentage, so the normal range that I've memorized is between 30% and 50%. So if anything lower than that, I consider it to be iron deficiency. So, but the ferritin being low is one of the indications that probably there is iron deficiency. So iron deficiency as part of this presentation. So a normal haptoglobin, well, we saw the bilirubin direct and total, they were within normal limits. LDH, haptoglobin. So all of these I cluster them as markers of hemolysis, and therefore all of them seem to be within normal limits. Although of course what we should have in mind is that someone with hemolytic anemia, so hemolytic anemia can come in events, and therefore maybe the patient is not in a hemolytic event, but because this patient's steady state hemoglobin is between 7 and 9, a hemoglobin of 5 is low, that is 2 units less than than the normal HB that she has, and therefore uh, if she was presenting with an acute hemolytic episode, we expected to pick to pick elevated markers, and therefore I think hemolysis is not a very huge consideration in this patient, given the normal levels of these markers of hemolysis, and therefore up to this point. So what I'm seeing is a signal for iron deficiency mostly. Although now one question that I should ask myself is, yes, we see a microcytic hypochromic anemia, which in itself is not conclusive that this is iron deficiency anemia. And yes, as I said, iron deficiency anemia can come with can be hypoproliferative, meaning, because I think a picture that we have most of the time is that someone with iron deficiency anemia is expected to have an elevated reticulocyte count because the bone marrow is reacting. But then, so you see that mostly with hemolytic anemias, and so impairment in maturation or erythropoiesis, as I said, iron can fall in both categories, and therefore a low reticulocyte count can tell us a number of things. So one, we could be talking of, and I'm not sure if I'll articulate this well, but then you have pure red cell aplasia. That is one of those conditions. But then another one is iron deficiency. That is one of the other, I think, one of the differentials that I'm considering high on my list. Although questions that I should have now is, what if it's not iron deficiency? What else can come with a microcytic hypochromic picture, low ferritin, uh, and then so the markers of hemolysis are normal. These abnormalities that we are seeing, and a low reticulocyte count. Yeah, I think those are questions that I have. So, Joseph, I think that those are my thoughts for now, that I'm entertaining that this anemia that we are seeing is most likely iron deficiency, and and so just to because we also seeing that it's hypoproliferative in nature because of a low reticulocyte count, will definitely need just to make sure that we rule out differentials. We'll also need bone marrow aspiration and maybe trephine biopsy and do staining, including iron staining, in order to see how the iron stores are, and just to rule out some other differentials that can present with a low reticulocyte count and this picture of anemia. So those are things that I'll do next. Although, yeah, definitely for a patient up to this level, I would have probably already sent them to a hematologist in order to work out some other things. But then, so for especially that was well done to check the viruses, the triple serology, because especially hepatitis C, can come with these anemias, and as well as HIV and hepatitis B in general. But then with infections, uh, we did not pick anything that is pointing in the direction of chronic infections, because most likely, or chronic inflammatory conditions, because this patient, and so under those circumstances, the ferritin would also be misleading, because if there is ongoing inflammation, ferritin can be elevated, and that might fool you and not think of iron deficiency. But this patient did not report fevers, night sweats, weight loss, which are very likely with inflammatory conditions, including infections, autoimmunity, as well as malignancy. So we are not seeing those. Yeah. So Joseph, any other pieces of information that you have? I think I'm limited in differentials in this case. Joseph, you're muted.
Oh, okay, yeah. So the final piece of labs, so we did stool analysis, which was negative. Stool H. pylori antigen was negative, and stool for cut blood was also negative. And our case ends up here.
Okay. Interesting. So let me see. So this is a 27 years old female with chronic anemia, I should say. Chronic anemia, a steady state hemoglobin between 7 and 9, but when the hemoglobin drops below that, she experiences these symptoms of lightheadedness and others, and she has had multiple blood transfusions. Uh, no symptoms pointing in the direction of acute blood loss, no heavy menses, no GI bleeding, and that is evidence that she doesn't report melena, hematemesis, and occult blood is negative. So genitourinary, she does not have heavy menses. Uh, no symptoms. At least we did not pick any symptoms that are pointing us in the direction of chronic inflammation, no fevers, night sweats, weight loss. And then this patient does so apart from these symptoms of anemia, we did not pick anything else. Physical examination is unremarkable. Apart from being pale, she's not jaundiced, no lymphadenopathy. Systemic examination unremarkable. And then when we come to initial labs, we pick we pick isolated microcytic hypochromic severe anemia with a hemoglobin of 5.4 and low MCV, MCHC. The anemia seems hypoproliferative with a low reticulocyte count. The markers of hemolysis are within normal limits. And other labs, as far as I remember, so all chemistries, because so there are things like chronic kidney disease or renal dysfunction in general, which can present with anemia. These patients' chemistries were all normal. So the liver, the kidney, all within normal limits. Yeah. So my thoughts, as I said, I one of the differentials that I put on top there is iron deficiency anemia. And of course, I did not have complete pieces of information because I did not have serum iron. I had ferritin, which is low, but that is just one of them. We had ferritin, which, of course, I believe it also tells you. I mean, we had transferrin, which was within normal limits, but I was interested to see the transferrin saturation and serum iron. So, incomplete pieces of information. And yeah, of course, partly it could be my lack of deep knowledge in interpretation of these iron studies. Maybe the ferritin itself and transferrin maybe would be enough to give me clues. Then so I iron deficiency anemia is on top of my list. So another thing is pure red cell aplasia. I talked about it, but then of course I've not read the details of this in order to see if it fits the patient's presentation. So that's something else I consider, but I think this is mostly a problem of the raw materials, which is iron, that is causing this presentation. And so the level of iron deficiency has led to this anemia being hypoproliferative rather than the other sorts of anemia that we see with iron deficiency. So I think I'm still not very confident to say that I've come to a final diagnosis. So further pieces of information that I would need, as I say, bone marrow aspiration is important because we saw a low reticulocyte count, and therefore bone marrow aspiration as well as trephine, those could help us rule out differentials. But otherwise, I think iron deficiency is one of those that is on top of the list. Although uh, I think the chances that that is the correct diagnosis, so for me they are high, but I will not be surprised if I miss the diagnosis in this case. So back to you, Joseph. I'm ready to learn what transpired and where I should improve.
Any thought on the cause of iron deficiency?
Well, so the cause of iron deficiency, yeah, that's a good question. So with regards to iron deficiency, there is a number of things. I'm not sure if there are, and of course you said a sister. You talked about a sister who had severe anemia during pregnancy, which necessitated a blood transfusion. So I'm thinking, because, and again I think my, what is that, should it be my physiology, my biochemistry, or what exactly? But I think it's distant now. I miss some details on iron absorption. But then, so you can have iron deficiency because of I think reduced intake is not very likely, because if someone is eating a normal diet like everyone else, it's very likely that they get the level of iron is enough. But then, so issues could start with absorption, So I think again, from the history, I think I ruled out chronic inflammation. So chronic inflammation is one of the explanations for iron deficiency, because basically the iron is hidden. So these patients have hidden iron. We talk of hepcidin many times. So I think one of those things is maybe the patient is having a problem with iron absorption, although not anything apparent that we could pick, and therefore I think a trial of parenteral iron in this patient. Of course, after I think I would not end up here. As I said, I'll need a bone marrow aspiration, trephine biopsy, and maybe if I could maybe send the patient to another lab in order to do a full iron studies in order to see if we are dealing with iron deficiency purely. And if that is the case, then I would give a trial of parenteral iron in this patient and see how they proceed. So I think a problem would be with absorption. Now, what exactly is causing impaired absorption in this particular patient, and probably the sister, I'm not sure. So those are my thoughts. Now, Antimony is saying, what about thalassemia? Yeah, so uh, the issue, I think, that made me not go in the direction of hemoglobinopathies and membrane abnormalities is that I did not see a hemolytic picture in this patient. So with hemoglobinopathies, we see with hemoglobinopathies and many membrane abnormalities, including spherocytosis, elliptocytosis, and others. So sickle cell disease and thalassemia, these are hemoglobinopathies. These ones will present with hemolysis, and therefore the picture that we see would most likely be a hemolytic picture. And if it's hemolytic, the hemolysis in these patients is mainly extravascular. It occurs in the reticuloendothelial system, and therefore many times they do not have an iron problem because the iron is recycled. So that is the case in patients with sickle cell disease, and I believe the same for thalassemia. And therefore, actually, if anything, they are at risk of iron overload rather than iron deficiency. So that's what made me not think about those differentials. So, but we'll see what Joseph has for us, and this could be a learning opportunity for me. So yeah, Joseph, that those are my thoughts.
Yeah, thank you very much. And let's see. So, yeah, as you're saying, rightly, as since the hemolytic markers were negative and the severe low ferritin pointed to severe anemia, even if we don't have the TSAT. As you know, ferritin is, you won't use the ferritin unless patient is inflamed, which ferritin is an inflammatory marker, it can rise, so you can use the TSAT, but ferritin alone is enough to say iron deficiency anemia. But iron deficiency anemia is just a proximal diagnosis. You have to come up with what causes iron deficiency anemia, which was the case in this patient. And this is a 2015 article by the any Nejm, and it's very comprehensive in as far as iron deficiency anemia is concerned. And I read it and came up with some stuff that we'll see, but you can see stuff here which are not telling you the patient. For example, increased demand. This patient is not in that category. Environmental, not likely. So maybe decreased absorption. And you look at this list, maybe two things: celiac, sprue, atrophic gastritis, but others not likely. It can't be IBD. These procedures not likely. And then chronic blood loss is also possible, maybe from the GI tract, but the GU tract patients didn't have any symptoms. So maybe from the GI tract. Drugs, she wasn't on any of these drugs. And these genetics, iron refractory iron deficiency anemia, was something new for me, and I had to look on it. And the iron restricted erythropoietic, these patient who use maybe erythropoietin, and then there is a mismatch of iron supply and the erythropoiesis, they get iron deficiency anemia because of increased demand. Not likely. This patient wasn't on those medications. So let's see what is possible. One, celiac. But celiac without any GI or malabsorption symptoms is highly unlikely. But yes, we have a non-classic celiac, which you can have just extra GI symptoms without GI symptoms, but her symptom would be only severe anemia without any mucocutaneous arthritis, neuropathy, osteoporosis, or transaminitis. Again, less likely. And then patient, she was a doctor. She told me she doesn't consume that much gluten food, so she expected maybe in the times when she doesn't consume them, she wouldn't be anemic. So we didn't think that she has celiac. But at the end, we would need TTGA, IgA, TTG, IgA, and OGD with small biopsy to say it's not celiac. Atrophic gastritis, it can be asymptomatic, or you can have just dyspeptic symptoms, but there will be a concomitant low B12. As you know, atrophic gastritis, you have a loss of parietal cells, you have low gastric acids, which means you can't convert iron 3 plus to iron 2, which is absorbable. So you end up with iron deficiency anemia. But the parietal cells also produces an intrinsic factor. So you have also pernicious anemia from low B12. And this is important. If it's there as a pre-malignant, you have to be followed up. Again, it will need an OGD with gastric biopsy to say so. Erosive gastritis, peptic ulcer diseases, or even diverticulitis, they can be completely asymptomatic. And the patient had a negative stool for cut blood, but doesn't rule out this diagnosis. Again, you will need an endoscopy to say so. So this new diagnosis I read, the IRIDA, iron refractory iron deficiency anemia, this is a genetic disease. It's an autosomal recessive. there is a genetic mutation which leads to high production of hepcidin, and you diagnose it once you see a patient who is what you think is iron deficiency anemia, but there is no response after 4 to 6 weeks of oral iron, and the response is defined as an increase of maybe at least 1 gram of HB when you use iron, which was the case in this patient, but it's not true. The presentation in the e-reader, they have a low T-sat and a normal ferritin. So we expected the patient to be normal because it's a picture like that of anemia of inflammation. They have a normal ferritin because it's just hepcidin is not there to tell the intestine to absorb more iron. The body has iron and it's not released to be used. So it's not irregular in this case. Other things that you guys brought up, I think, David, you've clearly said about the thalassemia, and I agree with you. But again, to send the test for thalassemia, you have to make sure that your patient doesn't have iron deficiency anemia. So if they have iron deficiency anemia, you treat iron deficiency anemia and then send the test for thalassemia. The reticular production index, yes, is low, but it's expected in iron deficiency. There is no building blocks for RBCs. So that's why there was no need to go for bone marrow and stuff like that. Now, the thing is, this patient, being aware of everything, she declined endoscopy. She said, even if you find those things that you're saying, then what? You still give me IV iron and I'll go on with my life. Still convinced about the trophic gastritis, that if it's a malignancy, you need to be followed up by saying, oh, all those years, maybe more than 10, if it was malignancy, I will be there for malignancy. And she said no any other further testing. And then she's just currently on chronic IV iron that she receives on a frequent basis. And yeah, so I don't have a final diagnosis like you, but this is the case that opened up for me, like to read a lot of differential diagnosis as far as iron deficiency anemia is concerned. And in the literature, I also found that it's not just this patient. There are other patients. I was reading a series of patients that no one knows whether they have iron deficiency anemia, but someone thinks that there is a problem with absorption, but no one knows exactly why they have iron deficiency anemia. So they are kept on chronic iron, IV iron, and life goes on. So that was the case today, David.
Thank you very much, Joseph. Well, so again, medicine is very humbling always because so here is a patient who comes with anemia, and I so from the way you are telling me is so what I pick is that most likely you also had the most of the same issues like I had, and so this is something that becomes very apparent that iron deficiency anemia, but see the way we struggle with it. So from considering what else could be explaining this presentation and many of these differentials that we are considering. So and I saw something. Saad mentioned something about the Menza index. Maybe later on, Saad, you can unmute and tell us about this because for me, it's the first time I hear it. I'm not sure if Joseph you've heard about it. Ruling out thalassemia from this index that Saad is talking about. Maybe in a few minutes, Saad, you can unmute and tell us about it. So thank you, Joseph, for the case because it jogged my mind. And I think many times when we encounter cases like these, a reflex would be okay. I wake up and make sure that other systemic conditions that could present with anemia, I've ruled them out, and then I would say, okay, it's probably iron deficiency, or there could be something else. I would send this patient to a hematologist to check them. But then, a physician being a physician, you have to have all this in mind. So thank you very much for bringing up the case. Yeah, so we still have some minutes. So, Saad, if you are there and you can unmute yourself and tell us more about this, I hope many of us will have something new to learn today from that. Saad, are
Yeah,
you there? Oh, Saad has already left the call.
yeah. So I think I've used it. So it's I remember using, but there is a calculation you can enter even online calculator. And the thing is, I think it was developed for kids that you have a kid with anemia. You want to tell, is this iron deficiency vis-a-vis thalassemia? Like, what are the possibilities? And yeah, if someone Googles there's a calculation. I think you take hematocrit divide by RBC, stuff like that.
Yeah, so Tom is there. Tom, I see your hand up. Please welcome. You can unmute and speak.
Yeah, thank you, first for the nice presentation about the Mensa index. Of course, I'm not sure when was the last time the patient received transfusion, but I think that can affect. The calculation is you take the MCV, you divide by RBCs. So differentiating iron deficiency and thalassemia, in iron deficiency, we also expect maybe we may have hypoproliferative. So you may have low numbers of RBCs. So when you divide, your ratio will be higher, saying more than 13, more than 13. But for thalassemia, we expect that the RBCs will be either normal or high. So your index then will be less than 13. Then you make a conclusion that this is maybe your thalassemia. So I'm not sure if this patient was transfused recently because that can affect the index. But that is it about the Mensa index. Thank you.
Thank you very much, Tom. Uh, I've learned. So see, medicine is very broad. So for me, it's the first time I come across it. Is there anyone else with? We still have some minutes. Anyone with any questions, any comments, anything to share? Please welcome before we close. Yeah, I do not see any other hands apart from Tom. So if there is nothing else, uh, we still make a call to remind people that we need cases. So I know that you people see a lot of challenging and interesting cases that we can learn from. So if you have any, whether it's complete or incomplete, you can bring it and we'll learn something from it and maybe help the patient. So a call for cases and another one is a call for discussants. Yeah, so in order to make this more interesting and not always be monotonous hearing from the same discussants, we wish to have more discussants. So if anyone is interested, uh, that doesn't need permission. So basically, when we are just starting the presentation, you can just volunteer and discuss the case, whether solo, if you want to discuss alone, or if you want to pair with someone of your choice. You can also do that, so we can learn from many different people. So otherwise, if there is nothing else, Joseph, do you have anything?
No. Good night.
Okay, have a good night, everyone, and see you next Sunday.